If you enjoy listening to clinical conversations, why not become a member of the Royal College of Physicians of Edinburgh? Our membership provides you with access to the RCPE educational portal, the live evening medical updates, and you have options to view the symposia both in person or online. If you would like to learn more about this, please go to the Royal College of Physicians of Edinburgh website.
So hello and welcome to this episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainee and Members Committee. My name's Kat Ralston and I'm a member of the TNMC as well as a Medical Education Fellow and Medicine of the Elderly Registrar in Edinburgh. And today I'm delighted to be joined by Dr Matt Lambert to talk about hyperacute stroke. Matt's a consultant in stroke and medicine of the elderly in NHS Tayside and is also the National Clinical Lead for Stroke in Scotland. Welcome, Matt.
Thanks, Kat.
Thanks so much for joining us. It's great to have you today on the podcast. So today, like I said, we're going to be talking about hyperacute stroke, which I think is a really important topic, and you'll tell us a bit more about that in a second. But I wondered whether you might have a case that can set the scene for us and just let the listeners know what kind of thing we're talking about.
Yeah, sure. Best example to illustrate sort of how things have changed recently is a patient I had a couple of years ago now, who a 45-year-old lady, previously completely fit, well, completely independent, working, etc., presented to us one Monday morning with a large left hemisphere stroke, so a big dominant hemisphere stroke, completely plegic down her right side, completely dysphasic, so couldn't say anything, couldn't understand anything we were saying to her as well. So clinically, from the outset, we knew this was a big stroke. She got a CT, got a CT angiogram, and she was thrombolyzed pretty quickly after arrival. But a CT angiogram also showed she had an occlusion of her sort of left middle cerebral artery, which again fitted with her symptoms. So luckily, it was at that time we just started doing thrombectomy, and so she went pretty much straight away to the intervention suite with our colleagues in interventional radiology and had a thrombectomy. She was one of the first thrombectomies we did in Tayside. They managed to get the clot out of the middle cerebral artery on the left. And after sort of brief period of theatre recovery and then came back up to the stroke ward, already we were really impressed with how well she'd done. You know, even by next day, that right side was pretty much back to normal with just a little bit of drift in her arm and leg. She was speaking again. We were able to have a conversation. And she actually went home after about 3 or 4 days in hospital. And to me, it was just this perfect example. You know, we have all the evidence that we'll talk about later on in terms of the benefit of thrombectomy, but that people like that in the past, either she would have, even with thrombolysis, probably been left with a significant disability and requiring care for the rest of her life, or potentially died. And to see her turn around and improve so quickly, it shows what life-changing and life-saving treatment it is. And I understand she's now back skiing and stuff like that, so she's back to pretty much 100% how she was before. So just a great example of how things have changed and progressed in the last few years.
Yeah, what a powerful story. And I guess what a case to have as one of your first thrombectomy candidates as well. That can sometimes be helpful instead of quality improvement and things, isn't it? Those stories where you think, actually, this is really life-changing for patient outcomes. So yeah, thanks so much. That was a really nice example. So it'd be useful just to think about, what are we talking about when we're saying hyperacute stroke?
Well, it's kind of changed and it is evolving a little bit, and that brings some challenges with it. So previously, hyperacute stroke would pretty much meant within the first 4.5 hours of a stroke onset, because that was based around thrombolysis data, what could do with thrombolysis, and the evidence previously around the benefit within that first 4.5 hours. However, with the advent of thrombectomy, but also those who have intracerebral hemorrhages, there's more and more evidence of things we can do in the early phases of a stroke that can really make a difference to people's lifelong effects from the stroke. So it's kind of expanded a little bit. Just for infarcts, for example, there's now evidence that thrombolysis in selected patients, if you have advanced imaging, can benefit some people out with the 4.5 hours that previously was our quite strict time window. Thrombectomy, again, there's evidence in selected patients that up to 24 hours that some patients will benefit. And so we have to be careful that we don't rule out people who present with a stroke and say, you know, if it's been 12 hours or so since it started, we need to be sure that we're not ruling them out of treatment, which could still make a difference. And then with bleeding as well, those who have an intracerebral hemorrhage, there's good evidence for treating hypertension in the first 6 hours. So it's a lot longer for pretty much anybody potentially, if it's undifferentiated and they either presenting to ambulance service, ED or wherever, presented within the first 24 hours, there is potentially stuff we can do for all these people if we assess them appropriately, get appropriate imaging to see what they may or may not benefit from. So yeah, it's kind of expanded a lot beyond what it was previously, which does bring some challenges in terms of resources and how we organise our health services, etc., and also education and updating all these different services like A&E and ambulance services, etc.
Yeah, so goalposts have changed a wee bit in the last while, which makes that difficult. And people have this 4.5 hours sort of ingrained in their head, don't they? And it's difficult to sort of subvert that. So a lot about services and education around that. But I guess from what we're saying, it's really a time frame in which there's something meaningful you can do that will make a difference in outcome. And that will change as the evidence changes over time and has changed a bit. Maybe a rule of thumb being sort of the first 24 hours for most things, we should be thinking about, is there anything we can do?
And that's a really good point. It's those patients where we can make a difference to either the extent of their infarct by reperfusing them, or if it's a bleed, reduce the extent of the bleed because it's still an active process at that point, compared to the kind of acute phase where the stroke's happened, it's kind of completed, and it's more into secondary prevention and preventing complications, etc. So it's still a bit where you can reverse or prevent progression of the stroke.
Yeah, no, that makes absolute sense. So we've kind of alluded to this already, but why is this sort of golden time so important that we think about hyperacute stroke in this way and we're bothered by it? Why is it so important?
I think just, again, it's to salvage as much brain as possible because there's more we can do now. And by salvaging brain tissue, that then has a knock-on impact on the longer term effects of the stroke, or hopefully less longer term effects than the stroke. So that's the kind of importance, is just recognising things we can do. I was just reflecting on this the other week and showing my age here. I looked at my Davidson's textbook from when I was at medical school. So that must have been published about 98, 99. It was just before I started medical school. And the section in stroke was about half a column, which basically said, do a CT scan at some point, maybe give them some aspirin and see what happens. And that was the extent of stroke treatment. So again, just that progression in 20 odd years of the amount we can do is startling. But unfortunately, there is still that kind of cultural lag in certain bits. I see that in day-to-day practice of people who don't specialise in stroke, who don't see stroke that often, this kind of perception, no, there's not much you can do anyway, is there, for stroke? There's this kind of lack of recognition of this being an urgent emergency thing that you need to assess quickly and get imaged quickly and then deliver appropriate treatments, etc. So I think that's why it's important just to sort of raise the profile, because there is so much more we can do than even a relatively short period of time ago.
Absolutely. And you kind of touched on this, but it might be useful just to go through what's happened with the evidence in terms of hyperacute stroke over the last few years, thinking about thrombolysis, thrombectomy.
So if you think about thrombolysis, first of all, so the evidence for thrombolysis has been around probably just coming up to 20 years, not quite 20 years. There was a bit of a wobble about 2011, 2012 when I was a registrar, because there were a few letters in various journals and stuff, people questioning the evidence around it. And that led to another meta-analysis and systematic review of all the evidence around thrombolysis, which came back and did show there was still a benefit from thrombolysis. And that shows essentially that what we're looking for, and this is why I have to quite often get across to my A&E colleagues who are a bit upset sometimes when next day the patient isn't entirely back to normal, that it must be not the right thing to do or fail, etc. But that what the trials show is your odds ratio of having a chance of being independent or surviving at 90 days is better if you get thrombolysis in appropriate patients than if you don't. And so that kind of slightly longer time period increases your chance of outcome. And I suppose the other key thing from the evidence is that although all those meta-analyses showed there was benefit up to just over 4.5 hours, the sooner you give treatment, the better. So again, there's this weird psychological thing. You can think, I've got 4.5 hours to deliver thrombolysis, so I can take all the time in the world and take up to 4.5 hours. What you want to do is thrombolyse at an hour rather than 4.5 hours, because your odds ratio of having a better outcome at an hour is much better than it is at 4 hours. So although there is a time window, the sooner you can deliver treatment in that time window, the better. So that's sort of the main evidence base around thrombolysis. I suppose the more up-to-date things is around the agent. So what we have used, or still use at the moment, is alteplase, which is a bolus injection then followed by an infusion over an hour. There's been a few trials recently looking at tenecteplase, which is an alternative thrombolytic agent, which has a slightly pragmatic advantage of it's just a bolus, so there's no infusion afterwards. And that is showing promising evidence in terms of being at least equivalent. The trials done to show non-inferiority to alteplase, and that does show that it seems to be as good as alteplase. So that has now been introduced into the national guidelines for stroke as an alternative. And that has a real benefit, I suppose, for those patients when we get onto models around thrombectomy, for those patients who have to transfer from one hospital to another to get thrombectomy, because it's a lot more complicated if you've got a patient in the background that's on an infusion. If you can give the drug and it's done, and then can go and answer they're not an infusion, that's so much easier from a practical point of view. So I think that's where it's going to have a big impact in just that ease of use. So the other evidence, I suppose, that has come that's relatively recent in the guidelines around thrombolysis is around the slightly extended time window. So we know that everybody's brain progresses at a different rate. So some people, their tissue death progresses really quickly, and actually at 4.5 hours, it's probably too late in those people. The brain is already died. They've got very poor collaterals, something like that. That means the brain's already not salvageable. Whereas other people at the other extreme can be a much more slower progression, and the brain can hang on for a lot longer, often if they've got good collateral supply that keeps things going. And so actually may still have brain tissue that's under threat but not yet dead, up to 9 hours. So more recent guidelines have potential up to 9 hours treatment, but that relies on having access to extra imaging to see in that individual, is there still salvageable brain tissue? So this is what we're talking about by the penumbra. So where you've got brain tissue, where you've got the core, which is the cells which have died already, and you're not going to save by reperfusion. And then you've got this penumbra around it, which is under threat, but if you reperfuse it, hopefully you'll get the supply back to that part of the brain. So you can either use CT or MRI perfusion scanning, or even just MRI with diffusion-weighted imaging and flare mismatch, which is a different technique of looking to see, is there salvageable brain tissue in this person, therefore it might be worth treating with thrombolysis and a longer window. So that's kind of where we are with the thrombolysis side of things. In terms of thrombectomy, so there were a whole number of trials that are all published around the same sort of time. So people have been trying this out across the world in different places for quite a few years, and innovators and stuff developing techniques and developing catheters and stuff like that to do it. And then there were a whole bunch of trials all got published around the same time, I think about 2016, 2017, all got published at that same time, which showed, again, overwhelming benefit. Initially, the initial trials were within the first 6 hours of stroke onset. So again, it's at the very acute end. And in that, the numbers needed to treat came out as about 2.6. So again, it's one of the best treatments for any condition of anything in terms of benefit. So that was really reassuring. Since then, I think this is where there's a constantly evolving field, and actually places things like guidelines really struggle to keep up because there's more and more stuff evolving all the time. So at the moment, people are now looking at longer time windows, people who've got a larger area of core infarct at the time they present. So there's now evidence that in up to 24 hours in selected patients where you've shown using perfusion scanning that there's a mismatch between what's dead and what's salvageable. I say also people in the past where we thought actually it's a large core already and therefore there's going to be no benefit. Again, there's more evidence emerging that those patients might also benefit. And not all this has made it into guidelines yet because there's so many trials ongoing and coming out all the time, and there's always a bit of a lag before they make it in. So it's quite a dynamic thing we have to keep on top of, and I struggle to keep on top of it with a stroke consultant because there's new stuff coming out all the time. So that's where the main evidence around thrombectomy is. I suppose the other thing to say around thrombectomy and thrombolysis and how they interact. So at the moment, those people who would benefit from thrombolysis, we still give thrombolysis and they can get thrombectomy on top of that. And that was mainly because the initial trials, people were eligible for thrombolysis. They couldn't really withhold that. It would be unethical to withhold an evidence-based treatment to try a new treatment. At that point, we didn't know if it benefited or not. But there have been other trials since then looking at, should we still be thrombolysing people who were going for thrombectomy? And the indication is that at the moment, if there is an indication for thrombolysis, you should give both, give thrombolysis, and you can still get thrombectomy on top of that.
That's helpful to know. And it's just really fascinating to hear. It sounds like a really exciting field at the minute. There's so much happening in stroke, isn't there?
Yeah.
And even for me, I'm a medicine of the elderly reg, but hearing about tenectis plays and things and about the windows, a lot of that's new. So I guess just underlining how much we need to be trying to keep up to date ourselves and looking at the guidelines and things and checking them before we assume it's what it was 2 years ago.
And again, that brings its challenges. So the guidelines have updated. Not many people are using these extended windows. Again, it's to do with resources and pathways and being able to access this. So for example, locally, I can't easily access CT perfusion or MRI as an emergency scan. And that's, again, the same across a lot of the UK, that the services keeping up to be able to deliver what we need to deliver, particularly in this case in terms of imaging, is a real struggle. So although the evidence shows this benefit, in practice we're lagging behind in being able to deliver that because our resources and pathways aren't designed to do that yet.
That means the communication around it is really tricky as well, because you're trying to get one message across and saying, well, in hours, you could maybe do this. Out of hours, you can't. That's really challenging for teams who are not specialists to do. So there's a knock-on impact in terms of the whole message around that, which is tricky as well.
Yeah.
Thanks for taking us through. I think one of the things that always hit me when hearing stroke talks is around numbers needed to treat, and it's just wild. So you said for thrombectomy, sort of 2.6. And I think for thrombolysis, it's sort of fairly similar, isn't it?
Yeah, so it depends again what time window you do it. If you within first 3 hours, it is similar. If it's between sort of 3 and 4.5 hours, so the longer you get from the onset, the numbers needed to treat goes up because there's going to be more people who potentially don't benefit. It's the same principle with thrombectomy. So again, although there's these time windows that you benefit within the first 6 hours from the initial trials, and the sooner you reperfuse, the more brain cells you save, and therefore the more function you save. So all these things, I think that's the risk, particularly now with policy settings. So people go, oh, you've got 24 hours to deliver thrombectomy now. No, actually, that very few people will still have a brain that's still suitable for thrombectomy at 24 hours. Ideally, you don't want to wait till next morning. You want to do it at 2 a.m. when they have their stroke. And it's trying to keep that message up as well. That doesn't mean we can just let everybody wait longer. We still need to deliver all treatments as quickly as possible.
Yeah, I've definitely heard that before, saying, oh, they've just come in. It's only been 30 minutes since onset. We've got ages. And that's that fallacy of that. And I think that's part of where that time is brain comes from.
Absolutely, yeah.
Which always just goes round in my head in a loop whenever I'm seeing anyone like this. So that's kind of the concept that, with every second, minute going past when they haven't had treatment, more brain cells are dying.
I think it's 2 million neurons you lose every minute of a stroke. So yeah, it's just so quick and so dynamic.
Yeah, so I think that's something that's useful to keep in my head, I guess, to try and keep the time pressure up when you're seeing these patients. Great. Well, thanks for taking us through the evidence. And I wondered, so this sort of podcast is aimed towards the generalist, I guess. So we're thinking about general medic, seeing people on wards. And I guess anyone could come across someone having a hyperacute stroke. I certainly, working in a district general as the MedReg on-call, would be the first person to see someone in A&E with stroke thrombolysis, or you come across them on the ward. It could be a medical student, an FY doctor. So I think it's useful to think about that approach to assessing a patient as a generalist with hyperacute stroke, because it's not as straightforward as you might think, thinking about what we really need to be hitting in that time. Would that be okay?
Yeah, and you're right, and it's like having that kind of focus, balancing that time, because you want to do things quickly, but also getting the key information. So the first thing I always kind of ask myself when seeing a patient, is this actually likely to be a stroke? So there's lots of people who get referred to us as a stroke team, and again, imagine you as a med-reg, somebody's thought, is this a stroke? And actually, it turns out not to be a stroke at all. So the first thing I always try to do, actually, is this in keeping with a stroke? So is it a new focal onset of symptoms? Can you tie it to one part of the brain? Is it acute for a start? It's not that it's happened yesterday and the nurse has just noticed at 8 o'clock this morning. Or are there other clues that there might be something else going on? Have they had a seizure, and is it post-ictal? Have they been hypotensive? We get called to loads of people who've collapsed in the toilet and it's actually just a vagal episode. And then particularly if they've had a stroke in the past or something, and they might have a little bit of focal symptoms briefly as they're kind of coming round. First thing is just trying to narrow down the actual presentation of it, and is this in keeping with a stroke disease? Then knowing the time of onset, if we know, and if it's not been witnessed, when were they last seen? Well, that helps you then know, when does the clock start ticking? How far through the stroke are we? Another useful thing to know, I think, is what their previous function was like, because that becomes really helpful in the decision around whether you're going to thrombolyse or do thrombectomy or not. So at one extreme, if somebody is completely bed-bound, dependent at the best of times, and they've had a stroke and you thrombolyse them, they're going to get back to being completely bed-bound and dependent. So again, their benefit from doing hyperacute treatments is pretty low, whereas if you're completely independent beforehand, obviously you've got a lot more potential benefits. So again, getting an idea of what their previous function is like is also helpful. Other key things in the history are anticoagulation, so that can be a contraindication to thrombolysis, not to thrombectomy, but it is to thrombolysis. So again, knowing if they're on anticoagulation, and if they are, when they've last taken it, have they actually taken it in the last couple of days or not. And they're kind of the key things in the history that I want to know. Then in terms of examination, blood pressure is really important, more when we come on to the decision later on about thrombolysis or not. Knowing what the blood glucose is. I've been caught out a few times where they think someone's having a stroke and actually they're just really hypoglycemic, and you treat that and amazingly they all get better. So has somebody actually checked a blood glucose? And then doing a relatively focused neurological examination, but ideally getting an NIHSS, so that's a National Institute for Health stroke scale, which is a bit of a tongue twister. So that's a multi-point scale where the more severe the scoring is, the more severe the stroke is. So 0 is completely normal, and there's some really good training around that online. So the American Heart Association have done it. So it looks slightly dated now with lots of dodgy 90s suits, etc. and haircuts, but the NHSS has not changed since then. So some really good training materials anybody can access online through the American Heart Association. So that's really helpful to have an NIHSS, because it's kind of common language that we use in stroke just to kind of communicate how severe a stroke is. It also means then when you can reassess it and you can see if things have got better or worse, you can almost have a baseline and see how things have changed over time. So that's probably the main things in examination. We don't need a full examination unless there's some concern about them having had some GI bleeding or something else that might contraindicate, had a significant head injury, to make sure they're not going to then hose out the back of the head because they've cracked the back of the head when they've had a stroke. But there's no need to do a full examination. It's just going to take time and not really going to change the overall decision making. So just focus around the neurological examination, BP, blood glucose, and take it from there. And I think that's enough information to then hopefully be able to make a decision. Sometimes from history, it's not always possible to know whether it is a stroke or whether it's a stroke mimic. There's some things we don't know until, particularly I'm thinking around people who've got functional neurological weakness. At the time, you can't really tell. And again, imaging doesn't really help you there, because often, and what you're hoping for with imaging, actually it's pretty normal that there's not any established damage. So it's sometimes down the line we realise actually they never had a stroke. But the evidence would suggest if you've got a pretty normal looking brain structurally and you thrombolyse it and it turns out to be functional weakness, for example, the risk of causing bleeding is pretty slim because the brain's structurally normal, so that the risks are pretty low. So I think all stroke consultants have probably thrombolysed multiple people who then turn out not to have had a stroke. But if the brain's pretty normal, otherwise it's unlikely to cause much harm. So they're kind of the main things I take in history and exam.
think that's really helpful. I think I certainly have verbalised someone who turned out, I think it was functional weakness or a migraine or something, I can't remember, but they were absolutely fine. I think you get a little bit obviously worried about thrombolising something that's not a stroke. It feels like there's that balance between time as brain versus getting the right diagnosis. But there does need to be balance there, and you can't go for hours digging into the history and doing a detailed neuro exam. You'll actually just need to make a decision.
And again, this is where better access to advanced imaging might really help with these. For those ones where I think this is most likely a stroke, but I'm not 100% convinced, but I can't get access to an MRI quickly. I can't get access to CT perfusion quickly. Sometimes CT angio can help you because you might see an occlusion, you think, actually, at least I'm treating a blockage in an artery here. CT perfusion and MRI, again, because the diffusion weighted changes on MRI show up pretty quickly. So again, with one of my colleagues has had a bit of luck a week ago when they managed to get an emergency MRI, which is like hen's teeth, without having to wait ages. Again, it's that balancing. If you're going to wait half an hour for an MRI, you think, actually, I don't really want to hang on that time. Whereas if by some miracle you can get an emergency MRI and say, actually, this is an infarct we're treating, it may just help give a bit more evidence and reassure you. But some of them are quite clear cut when they come in. It's very unlikely to be a stroke mimic. You think this is almost certainly a stroke.
Yeah, I was thinking about that when you were talking about CT perfusion and things, and thinking some of this could be quite useful if you're feeling a bit uncertain, but also I guess it's like everything in medicine, balancing those risks. What have you got to gain versus lose by treating or not treating? And part of that is around discussing that with the stroke consultant as well, which we'll get onto.
The things I suppose that sometimes can be more challenging to identify those with posterior circulation strokes. And that I suppose that there's slightly less evidence around that because most of the trials thrombolysis were anterior circulation strokes. Pretty much, there's been a lot more evidence thrombectomy for anterior circulation strokes. And that's probably because posterior circulation strokes are, not as common. And so it's harder to get enough people in trials to get evidence out of it. But also I think posterior circulation strokes can be a lot more challenging to diagnose. I still find it really difficult and challenging at times because they can present in slightly non-specific ways, poor balance, ataxia, vertigo. There's so many other causes that can potentially cause those symptoms as well. It can be quite a stuttering presentation often as well, so symptoms can come and go, and there's just such a wider differential with posterior circulation, so that can be a real challenge. I would thrombolyse a posterior circulation stroke if I was pretty sure it was, and likewise there's increasing evidence for particularly if it's basilar artery stroke and intracranial vertebral artery stroke for thrombectomy for these patients as well. But yeah, rare real challenge because there's all sorts of mimics, from labyrinthitis, benign positional vertigo, hypoperfusion episodes that can all cause kind of very vague posterior sounding type symptoms.
It's useful to know that these symptoms can be a stroke, to have that in your mind in the differential, and think about onset time and whether they're within that window, and perhaps then do your examination, then discuss with the stroke team on call and see what they think.
I think that's the key. I think it's just having it at your back in mind that, so no pun intended, that these could be posterior circulation strokes with these slightly non-specific, dizzy, poor balance, diplopia kind of things could be a stroke, and not to miss that opportunity.
And just thinking about imaging things, we talked a bit about imaging. I guess in quite a lot of places, your imaging is going to be a plain CT if it's out of hours or if you're in a district general hospital. So people often talk about sort of the timing of that. So a patient might come in, someone's on the phone to CT, and then you're midway through your assessment and they want to whisk them away and things. The timing of that CT, when do you think that's best?
I would probably, after you've actually got the history and examined and you're pretty sure this is a stroke, again, because we're saying probably quite a targeted examination, hopefully most radiographers and radiology departments wouldn't mind hanging on for 2 or 3 minutes while you complete a neurological examination if they ring in the middle of that. I think it's useful to complete that bit first, because also that allows you to say, you examine and go, actually, I don't think this is a stroke, so actually we can stand all this down. We don't need to rush them off for emergency CT just now, which is also helpful for resource utilisation and keeping radiology departments happy, etc. So I think I would probably do it as soon as you can after. For example, how we work locally, when we've got somebody coming in as a pre-alert with a stroke, we pre-alert our radiology department so it's at least on their radar. They've got an idea that somebody's coming around this time, and if it turns out to be a stroke, they're going to need a CT. So they can either not put somebody who's going to be a long CT scan on the table, for example. They can keep on working but not do anything that's going to tie them up for 30 minutes or so and delay the scan when the patient actually does arrive.
That sounds like a sensible middle zone.
Because you don't want them sort of standing still for half an hour doing nothing with a busy CT list. They want to carry on working through their workload, but at least then they're aware it's likely to be coming at some point.
And often, I don't know what you remember about being a reg, Matt, or thinking about what it's like in different places. So your experience going to stroke thrombolysis as a specialty stroke team in a tertiary centre is probably quite different from if you're the lone med reg in a DGH in the morning. Do you have any tips if you don't have a big team in terms of how to actually best use your time, best use your team when it feels very pressured?
First of all, actually, if you get a pre-alert, so most ambulance services, for example, will pre-alert into ED. So I think using that, and I think that varies between the different EDs, what they do with it. Some just take the details, oh, that's interesting, they're coming in. Others are actually very proactive and either, again, pre-alert, whether it's the med reg coming down or it's the stroke team in hours. Again, like here in Ninewells, the ED person sees them first to make sure it's like to be a stroke, and then the med reg takes over at that point. But using that time of the pre-alert, you can actually gather quite a lot of information from systems. So for example, are they on anticoagulation, get an idea what the previous function is, have they got any other past medical history, if they had major surgery in the last week or so that's going to potentially put you off thrombolizing. So try and gather as much as you can before they even arrive, because that's kind of bonus time in a way, because there's nothing else you can really do with that time. I think not doing anything that isn't needed. So there's a real, for example, getting people undressed in a hospital gown. Thrombolysis doesn't work any better if you're in a hospital gown than it does if you're in your own clothes. So I quite often have to stop ED staff. Just leave their clothes on, it's fine. I can assess them with that on. They don't need to have a gown on. They don't need an ECG really. If you want to, put a monitor on, but don't let it hold things up, and definitely don't stop everything to do a 12-lead ECG, because that's getting another 2 minutes of time gone. That's not really going to change your decision. So I think that real kind of concentration on don't do things that aren't needed to make that decision. And that can sometimes be really hard for some departments who, because they have almost their safety thing for other patients, we need to do this, and this, because that's what we do to be consistent with all patients. But it's trying to challenge that and say, no, that's a waste of time for this person. I think if you're not on your own, if you're hopefully there with a nurse, so you're not on your own completely, almost beforehand sort of agreeing who's going to cannulate, because it's quite good while you're doing an examination to have somebody else cannulating and taking bloods off. So the policy, for example, from the ambulance service is that they don't put in cannula routinely for patients with stroke, and that's because there's a concern that it leads to increased time on scene, because they're doing that, and if they obviously don't really want to be doing it whizzing down a twisty road and trying to cannulate, but it's useful to get that done really early on when they get arrived. So again, asking the nurse or somebody, that'd be much more better time spent cannulating than doing an ECG or getting them into a hospital gown. So doing that. Other things that can help sort of shave time off is, quite depends on pathways in different places. So for example, locally, it doesn't always happen, but if it's out of hours, I would prefer to be called if I'm on call at home at the time when you're about to go to CT, rather than at the time when the patient has already had their CT and you've got the results. Because one, if I've just been woken up at 3 a.m, I'm not going to be able to make a decision as soon as I've woken up. So what it allows me to wake up a little bit, it allows me to switch my computer on and be able to look at the scans and stuff and get all that booted up, and also to be able to begin thinking about the patient with the information you have at that point. So I think check with your own local pathways, because other stroke consultants in different places might not like that approach, but to have an early call to the stroke team so that they're prepared to make a decision. Other things I think are looking at is where you deliver the thrombolysis. So for example, locally we start thrombolysis in the CT scanner, so either while they're still on the table, again, it just shaves off another couple of minutes. So a lot of cases, for example, as a stroke consultant, I've often made the decision I'm not going to thrombolyse, just waiting for the CT1 to confirm it's not a bleed, or there's some other space-occupying lesion or something else that's going to be a radiological contraindication. But from the clinical history, etc., I've often almost made the decision before the scan, and that's just really confirming to me. So if in hours, you're doing CT angio or doing other imaging for thrombectomy, I then try and get on with thrombolysis while that's being done or being processed or interpreted, again to save having to wait another 5-10 minutes until everything's done. So I think there's little things that I just try doing things in parallel with other members of the team and not doing things which aren't important, I think are the two key things.
Yeah, I think that's really helpful. I think using that time before they come in, if it is a pre-alert situation, and, gathering information and allocating roles seems possible. And it's kind of like doing a cardiac arrest, pre-huddle sort of at the start of the day and things. So that feels sensible. And just thinking about, often it's like making up the alteplays can be a challenge as well. So I guess thinking about, is there anyone who can be making that up once you actually know this is a stroke, to have that ready for you, because that can often feel a bit of a challenge as well.
Yeah. So again, locally, what we do, most places do this, or in Scotland at least, we're encouraging most teams to have 24 hours a day to have a stroke nurse who goes down to all these stroke patients. One, because they hopefully familiar with stroke and stroke care and what's meant to happen in the pathway to help drive that. So because medical registrars, you rotate around all the time, you may not know the pathways in different places because you may not have actually been to a stroke before there. So actually having somebody who's familiar with the pathway is really helpful to guide and also to drive it, to sort of say, come on guys, let's get a move on, let's not hang around here. I suppose another thing that's really helpful is not waiting for porters. So again, locally, us as the doctor and the nurse just take the patient ourselves, and if the porter catches up, great. If not, but sometimes you can wait 2-3 minutes for a porter to arrive and you think, actually, let's just get them to CT, get it done quickly. So that's another sort of tip that we do locally.
Yeah, that's a useful tip. My dodgy driving aside, I've definitely done that before. In one of my other hospitals, we did kind of a walkthrough of where CT was versus where people came in. I think that's helpful as well, about how you're going to get that patient to CT and you know where it is. It's a useful tip. You talked a bit about sort of when to call the stroke consultant. I think that resonates with my experience, is that generally in my area as well, the stroke consultants are quite keen to get a heads up, particularly if it's out of hours, to say, look, this person, I think, had a stroke. This is information. They're going to CT. I'll call you back, but just your computer on and all that. And that is helpful. Is there anything else that you would say as a person receiving these phone calls, like what's really helpful in terms of what you want to know?
So again, I think it goes back to that bit in terms of the history and examination and just presenting it in a really focused way of age of patient, time of onset, was it witnessed, was it a last known well, what's their NHS like, what's the blood pressure like? So almost like a checklist of those features and kind of presenting it as such. We don't really care if they smoke or not, or all the other social history stuff. So just to really kind of focus on those bits we talked about before, these are the important things, because that also again makes it easier for us as stroke physicians to not get distracted by all the other stuff as well, so you get quite focused decision making. I suppose that's the other example of calling the stroke consultant early, is that again there will be cases where actually at that point you're thinking, actually regardless of what the CT scan shows, I'm probably not going to thrombolyse this person, so it means the pace can slow down a bit. Radiology don't have to drop everything to do this scan, because you're thinking actually whatever this scan shows, I'm not going to be thrombolysing. You might still say you need an urgent CT scan, but it's maybe not quite the same urgency.
Yeah. And I guess just to be clear as well, the decision to go for advanced treatment like thrombolysis thrombectomy is with the stroke consultant on call.
So in most places in the UK, definitely in Scotland now, I think pretty much everywhere is either by a stroke consultant attached to that board. For example, as South East Scotland, there's a kind of network of consultants who cover multiple boards out of hours. So yeah, pretty much all places, either stroke consultant there with the patient or remotely supporting that decision making. Yeah.
I feel that's just helpful. People listening and work in the UK, that decision is actually being made.
And that's a lot of work, because I know our local regs were worried at one time, oh my God, getting involved with thrombolysis, and feeling terrified they were going to have to make that decision, trying to reassure, say, no, you won't be making this decision yourself. You'll be supported.
And just thinking about thrombolysis first in terms of some practical points around it, I'm interested in how you're making the decision on when you thrombolyse someone. I've heard people say before, if they can't walk, can't talk, can't speak, things like that, or using NHS. What's your approach?
So this is probably something where there's probably quite a lot of variation in practice, because a lot of it is weighing up benefits and the risks. I remember when I was at Reg and doing training, we went to a training day and we didn't all agree on who would thrombolyse and not thrombolyse. And I think there is always going to be disagreement. So there's clearly those at one end of the spectrum who most people will thrombolyse, really big symptoms, NIHSS, really high, really early on, no other contraindications, pretty much everybody will thrombolyse those people. And likewise at the other end, somebody who's got very, very mild symptoms, just a little bit of drift or something, but not much else, or resolving symptoms, that and towards the end of the time when you think actually the benefits can be low, pretty much nobody would thrombolyse. And then there's this whole group in the middle where you could argue either way, and there's not a right or a wrong answer. So pretty much everywhere should have a governance process around this where all these cases get discussed to sort of make sure that nobody's being an outlier and stuff. But I think there's always going to be this grey case in the middle where you can make the case for or against, and half clinicians would say, yes, I would. Some are a bit more risk averse and would say, actually, no, I'm going to not treat those. And that's why it's hard to protocolise these things. And when we worked in the past with ED, when I started as a consultant, we didn't have a stroke on call rota in Tayside, for example, and our ED consultants did it pretty much autonomously, and they kept asking for us to have a protocol. There's so many bits that come into decision and weighing up risk and benefit. You can't really, without it being an A3 massively complicated flowchart, which nobody ever followed, you can't really protocolise it, because a lot of it in the grey case in the middle does come down to judgment and what your appetite for risk is.
I think that makes sense. And I guess that's why it's usually a bit of a collaborative conversation between you as the referring doctor and the stroke consultant. And it makes sense to be like that. So often I get asked, what do you think? Which when I was a junior reg, I found quite scary. But I think it makes sense.
But you're right. I suppose one of the things which can just give a pretty low NIHSS, which I probably would thrombolyse, was you mentioned dysphasia there. So again, somebody who, for example, has a stroke causing purely dysphasia, particularly if it's receptive, because that can really change a person's ability to understand the world around them. Although generally then you would tend to score a bit more in the NIHSS, because you wouldn't be able to answer the questions around following instructions and name of the date of birth. So you'd get more points than you do just for the purely dysphasic bit. But yeah, somebody who's dysphasic but still has a relatively low NIHSS, I tend to thrombolyse, because that can be quite a life-changing disability if that persists.
Yeah, so kind of impact on quality of life for that person in terms of what symptoms they have is something that's really important to think about.
And the other thing is, once a decision's been made within that time window, things might change. So occasionally, for example, we get a patient whose symptoms are coming in, they're improving, you think, actually, I'm not going to thrombolyse them because it's actually rapidly improving. And then half an hour later, the symptoms are a lot worse again. Because it is dynamic in that bit, blood pressure fluctuates or clot propagates, symptoms can get worse. So that's why even the ones we don't thrombolyse, our nurses would keep a really close eye on and keep doing frequent neuro-obs. And if things deteriorated, and it's within that time window, you might then say, actually, things have now progressed and there's much more benefit, and so I am going to thrombolyse. Whereas half an hour ago, they had pretty minor symptoms and I probably wouldn't. And that's a thing that's a bit more of a challenge out of hours when, there's a quick decision of, oh yeah, we're not going to do this. And then there's a risk that they then get lost and then nobody notices they've got worse and then you've missed the boat.
Yeah, absolutely. And we've talked a bit about the hypothrombolysis. So, at the minute it's alteplase, so kind of a bolus and then an infusion, and thinking about who can maybe make that up for you and whose experience is useful. You talked a little bit about where as well, and that can be sometimes a bit challenging if someone's had an acute stroke on a ward, and there can be lots of discussion around, well, they need to be in HDU before you can give them the bolus and things. What do you think about that?
I think it varies from place to place. So most big centres will now tend to either start the thrombolysis in CT and then take them to their acute stroke unit or hyperacute stroke unit, because HASUs or hyperacute stroke units are very much, that's part of what they should be doing, is caring for these people. But again, a lot of places like we do locally will start that treatment in the CT room before you even get back to a ward. I think the challenge comes more for those places that haven't got a hyperacute stroke unit or even acute stroke. So for example, some of the islands hospitals in Scotland, I'm thinking PRI, my other hospital, NHS Tayside, where there's not an acute stroke unit, and patients here go to medical HDU just because it's the safest place where they can get the appropriate level of monitoring. So it will vary from hospital to hospital depending on the practicalities of where they can safely do it and be safely monitored. But ideally, you want to do it as quickly as you can after the CT scan and start on the CT scan. And the gold standard would be then to go to a HASU, but recognising that not all places have a hyperacute stroke unit or a HASU to go to.
Yeah. So, get the bolus in at least and get things started while you're working out where the safest place is. And so we talked a little bit about where they're going to be, and each place will have their protocol for post-thrombolysis care, which should be detailed, and it will vary locally. And the other thing that we often have is things that you talked about, blood pressure as being important in thrombolysis. Do you want to just say something briefly about that?
Just that it caused a bit of confusion again, from particularly among medical registrars, because again it's kind of moved on a bit in the last few years, particularly with hemorrhages, etc. So from an infarct side of things, the guidance is generally to not thrombolyse somebody if their blood pressure is over 185 systolic or 110 diastolic. But if you can get that down urgently, you then might get it into a level where it's safe to. So most places have protocols for using intravenous treatment to rapidly treat the blood pressure to get it down and hopefully then maintain it at a level where it's safe to thrombolyse. So for example, we use labetalol, a few boluses first of all, got a protocol for this, and then potentially an infusion after that if it's taking more. And if you can get that down, it then can be safe to treat. So a lot of people who have strokes, infarcts, are hypertensive because there's a normal physiological response, and it helps improve perfusion, it's thought, as well. So if it's not above that, you probably don't want to treat blood pressure acutely in an infarct. Evidence actually shows it can actually make outcomes worse because you reduce perfusion. So it's really only if it's above 185, over 110, either of those are above that level, and you want to kind of keep it below that for at least first 12, if not 24 hours after somebody has been thrombolyzed. So that might require repeat treatments to get that down.
Yeah, I think that's helpful. So it's not an absolute contraindication, but we need to do something to get that down and keep it at that level. And what people often ask that what drug, but I think generally it will be on your protocol and what the staff are used to giving useful. So I think GTN, labetalol tend to be kind of common things.
Yeah, we tend to use a combination of those. And if it's going to an infusion, we tend to then go on to GTN. But again, different places will have different protocols. There is talk in Scotland, I don't think it's been developed yet, of developing a national hypertension and stroke protocol, because people move around, particularly trainees move around, to have a bit of consistency in terms of how that's done.
Yeah, it makes sense. And the other thing I guess we all have to do, or generally the person referring will do, would be having a conversation with the patient or the relative in terms of assessing capacity and then approaching that risks and benefits conversation. Have you got any sort of tips about that?
Yeah, so again, different people probably do this slightly differently. You're right, if the patient themselves has capacity, I try and discuss that with them, or if it's overnight, ask the registrar who's with them to have that discussion with them. It's that balance between doing this but not taking up so much time that delaying the benefit of the treatment. So if the person has capacity, I tend to explain that with considering giving thrombolysis, that we know that not everybody who we give thrombolysis to will benefit from it, and we can't tell before we give it if this individual is going to benefit or not. But I tend to say you've got a much better chance of having a better outcome if we give this. There's about 3% chance of causing bleeding into the brain, which would make things a lot worse. About 10 in 100 people have a net benefit if you treat them under 3 hours, and about 5 in 100 people have an overall benefit if you treat between 3 and 4.5 hours. I would say that we can't guarantee this will benefit you, but we know overall this will have more benefit more chance of having a benefit for you, and therefore I would recommend this as a treatment. Because I think often the patients are completely shell-shocked and trying to work out what's going on, and often, even if they do have capacity to understand it, may struggle to reason through that. Sometimes they might ask you to speak to a relative, which there's a relative with them, they're in ED or in the radiology department or wherever the patient is, it can be worth having a quick chat. Sometimes you just can't get hold of them, and that's the same if the patient doesn't have capacity. For example, they're really unwell or they've got dysphagia and you just can't communicate with them. If there's a relative there, I try to have a quick chat and discussion, but I wouldn't spend ages and ages and ages trying to track somebody down, because it's getting that balance between delaying an emergency treatment, and it essentially is a kind of an emergency treatment we're giving. So you don't think anyone would have a go at you for not gaining consent or discussion with a relative. It's practically very difficult to do that.
Yeah, I think that's helpful. And the other thing we've talked about before is it can feel like a very odd conversation with a relative if it's on the phone, because you're rapidly trying to explain this because you have this sort of time in your head. And what I've found helpful in the past is like a little bit of expectation setting at the start of that conversation. They look like this is a treatment that works best if we give it as quickly as possible. So I'm very quickly going to ask you a few questions and then I'll call you back and we'll go through this in more detail. Otherwise, it can feel a bit like you're kind of
cutting them off. Yeah, otherwise start asking about visiting times and stuff like that. Actually, I haven't got time to discuss that just now. We'll come back to that in a moment. Yeah, exactly.
Yeah, because it can feel like a bit of a challenging conversation. So I think that can sometimes be helpful. Okay, so that's kind of around thrombolysis. And I guess the last thing to quickly talk about is thrombectomy a little bit. What's kind of happening with that? What do we need to know about that as generalists at the minute?
So again, there's a bit of expectation setting more for the population level. So the services, I suppose, for thrombectomy are still in evolution in the UK in general, and in Scotland in particular. Lots of places in the world have really good services and 24/7 services for thrombectomy. In the UK generally, we're quite a bit behind the curve here. So that the patients who potentially benefit from those are those who have a large vessel occlusion. So by that we mean carotid artery occlusion, middle cerebral artery occlusion, and M2, which are the first sort of branches of the middle cerebral artery. Also posterior circulation stroke, so those who have a basilar artery clot or some of the intracranial parts of the vertebral artery. So if you've not got a blood clot in any of those areas, you're not somebody who will benefit at the moment. Again, it's an evolving field, and I suspect as technology and evidence progresses, we'll be able to go further and further into the brain and treat other clots. But at the moment, it has to be a sort of large vessel occlusion. So one thing has to be a large vessel occlusion. So to that, we at least need to have a CT angiogram to identify that there is an occlusion, see where that occlusion is. The timing, again, so within the first 6 hours, the evidence is not to need to do lots of advanced imaging to look for penumbras, etc. And if you can start treatment within 6 hours of onset, you would start in the 6 to 12 hours. So this is where there's a bit of variation in practice because it is such a movable feast in terms of the evidence. The current 5 Nations guidelines published last year say up to 12 hours that if you haven't got lots of brain damage just from plain CT and you've got a large vessel occlusion, you should still treat. And then between 12 and 24 hours, you should use CT perfusion or some other MRI perfusion to detect salvageable brain. I suspect that may change as it's that extended time window where most of the work's going on in terms of trials at the moment. So that is likely to evolve over the next few years. So yeah, large vessel occlusion in those arteries and can actually get access to a service. And that's the big issue at the moment, is having access. So for example, in Scotland, there's 9 to 5 services available in Edinburgh, Glasgow and Ninewells in Dundee. Edinburgh have a more limited service at the weekends. The other centres don't at the moment. And there's no service anywhere in Scotland overnight at the moment. And again, across the rest of the UK, it's very patchy. So some places in England have pretty much 24/7 service. Some places, again, have hardly any access at all. So it's a really patchy provision at the moment. So the key is, are you in a centre that at that time has access to thrombectomy, and then has that patient got a large vessel occlusion and salvageable brain tissue all within the correct time period? And that's the key, I think, is getting the appropriate imaging. So you need to at least get a CT and a CT angio to sort of see have they got an appropriate occlusion. And then ideally for these longer windows, depending where you work, some centres want CT perfusion, other centres are working without CT perfusion and using other techniques such as looking at collateral circulation and plain CT and CT angiograms to do that. So that's where I think there's a bit of variation.
It's useful just to think about the different imaging you might need for that. So CT, CTA as a minimum, and then thinking about what else you might have access to, particularly if it's after that 12-hour kind of period. And I think the other thing that is maybe useful to remember is that a lot of these services are in hours, but a patient may come in at sort of 3-4 in the morning and they might transition into that in-hour period. So I guess knowing what's available in your local area and thinking about people that might cross over into that.
And that's really true. I mean, so even locally where we don't have to move people on for thrombectomy, they can get it in-house, we have to really think differently. Now, you're right, those people who come at 3 in the morning, you can't do thrombectomy at 3 in the morning. So they may or may not be thrombolyzed at that time, but then we have to then think first thing in the morning, okay, this person's coming overnight at 8:30 in the morning when radiology's opening up and IR's opening up. We have to be ready to think they may still be within a window. And often what you need to then do is re-image them at that point, because actually, particularly if it's 4 or 5 hours down the line, the situation can completely evolve. So you want to clinically reassess them and see what they're like at that point, because actually it may have resolved and actually it's fine. You want to see have they got significantly worse. You can probably want to re-image one to sort of see what the brain's like at this point. So either plain imaging again to see what, so the thing called the aspect score, which is on plain CT to sort of see how much brain has been affected by a stroke. So you may want to see how much brain has been damaged either by plain imaging or by CT perfusion, depending which centre you're on and what the radiologist there is their preferred way of looking at that. And you also redo the CT angio to sort of see, is the occlusion still there? And so it's having those systems set up and to think, again, just because the decision's been made at one point overnight about one thing, don't forget that in the morning there may still be thrombectomy.
The last thing I wanted to pick up was, I guess thrombectomy has opened up a bit in terms of people who might not have been able to have thrombolysis in the past. So one of the areas is around the time window, but is there other situations that we can think about thrombectomy when we usually thought, well, we can't thrombolyse that person?
Yes, so I suppose the bigger one is around anticoagulation. So again, you can do thrombectomy when people are anticoagulated. So if somebody's anticoagulated, we wouldn't thrombolyse them, but you can still get a thrombectomy on top of that. So that's the big group of people, because there's always this group we thought, actually, there's nothing we can actually do hyperacutely for you, whereas they might be able to get thrombectomy. And then potentially other contraindications. So for example, somebody's had major abdominal surgery and you don't want to get thrombolysis because they're going to have a big bleed intra-abdominally. The risk of thrombectomy is less. Sometimes they do have to give sort of antiplatelets and stuff IV during the process, but again, they're generally not giving thrombolysis. So there's these other groups who might have absolute contraindications to thrombolysis, which wouldn't be for thrombectomy.
Yeah, absolutely. I remember someone coming in on warfarin and just, there's no way we're going to be able to, or it's banned 2 hours for, there's no way. And just keeping an open mind about there's other things that might be available for people that, in the past wouldn't be able to give one of these treatments to. Okay, well, we've covered a whole heap of ground there, I think, Matt. I wondered if you've got any last top tips you want people to take forward from listening to this podcast, thinking about their practice.
So I think just re-emphasising that thinking what considers hyperacute and just thinking that there's this potentially slightly longer time window and bigger groups of patients, so not ruling people out. So thinking around that. I think that thrombectomy is an evolving evidence base. So again, if there's a non-specialist, you don't need to keep up to date with that, but being aware that hyperacute window and what means hyperacute might evolve even more. I think the national clinical guidelines are really good. So they were published last year. So they can replace the previous SIGN guidelines, and a lot of what we've talked about today is covered in there in terms of the evidence base and what we should be doing. So that's worth referring to. They're quite accessible and they're all online, etc. So they're 5 nation guidelines now, for the same for England, Scotland, Wales, Northern Ireland and Ireland as well. So the other thing is that, stroke is really dynamic now. There's so much happening. And so if anyone's out there who's wanting to become a stroke physician, it is actually really rewarding, because there's more and more we can do from this end that we've been talking about, the hyperacute, all the way through the rehab. It's a really varied career, and with this increased amount of things we can do, there's even more need for a workforce, because someone needs to deliver all this. So I definitely recommend it as a career.
Yeah, nice little plug for stroke medicine there, like that. So thanks so much, Matt. I hope that's been interesting to the listeners. I've certainly learned a lot through having this chat with you. So thank you, and thanks for listening. Hope you join us next time.
The TNMC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.